And for this, we have our next speaker, Dr. Purusottam Chatterjee, a very renowned diabetologist and endocrinologist attached to Apollo Group of Hospital, executive at Diabetes Association of India, Bengal chapter. And to chair his session, I would like to invite Dr. Professor Dasharuthi Sarkar, senior consultant endocrinologist attached to Calcutta National Medical College and GD Diabetes Hospital, former faculty IPGEMR and SSKM Hospital, and along with him Dr. Sanjay Shil, renowned consultant physician attached to Peerless Hospital and CT Diagnostic Center. Over to you, sir.
So we are going to have a very interesting session right now, which is hypoglycemia and non-diabetic patients. We all know hypoglycemia in diabetics because of secretagogue or maybe insulin. So hypoglycemic drugs are there. But hypoglycemia in non-diabetic patients is, mechanistically speaking, is something different absolutely, and sometimes we as clinicians become a little bit confused. I mean, there can be various reasons for that. It may be fasting, it can be postprandial. Now, how does it work? What are the situations that we should be looking at? Whether we are having some insulin autoantibody or whether we are looking at adrenal insufficiency or pituitary insufficiency and so on and so forth. A lot of things can be talked about in this particular session, but I request you to make up some time loss already. Over to Purusottam.
Thank you, respected chairperson.
Purusottam is a brilliant DM student in IPGMR in our time, and also continue.
I'm very glad and fortunate to being introduced by one of my favorite teacher, and I owe some of my whatever knowledge about endocrinology to Professor Dasharuthi Sarkar. He was my teacher and also respected chairpersons. So thank you everyone, good morning, and I will also thank SDS Con for inviting me. Now, it is very important to understand that being a practicing endocrinologist and also a diabetologist, we see a lot of patients with hypoglycemia in the background of diabetes. Now, hypoglycemia without diabetes is a very challenging diagnosis, and it is very important to have a proper clinical assessment, diagnosis and management for a patient who presented with hypoglycemia without any history of diabetes. So I will try to make it a brief and to the point so that it will not bore you. So the first and important issue is that hypoglycemia, documented hypoglycemia in non-diabetic patient is quite uncommon in clinical practice. You probably have your experience in your day-to-day practice, and it can be presented as fasting, in post-meal state, and in any of the situations. So overall, it is quite uncommon in the background of non-diabetic persons. If we just like to have a definition and prevalence, now prevalence is probably not that robust data is available. Now, whatever data we have purely based on the in-house that hospitalized patient, it is around 30 to 50 per 1,000 hospital admissions, and it varies from center to center. This is an average data I have collected from the internet. But as far as the general population, in community setting, in our day-to-day practice, there is no verified data as far as the prevalence and incidence of hypoglycemia in non-diabetic patient is concerned. But there are 3 points we have to be very careful. There are specific population like elderly, populations with say chronic alcoholic, some chronic disease, some acute setting, may prone a person without diabetes to hypoglycemic episodes. So first thing, you have to diagnose a hypoglycemia. The classical Whipple's triad is being still taken as a gold standard, and 3 points has to be fulfilled. 1, symptoms related to hypoglycemia, biochemically proven hypoglycemia, and resolution of symptoms of hypoglycemia when you normalize the blood glucose level. These 3 points are very important to verify a clinically important hypoglycemia. These three are the points to be remembered as Whipple's triad. Now there are clinical symptoms. As you know, presentation of hypoglycemia can be very varied, and there are two sets of symptoms classically has been explained as autonomic symptoms and neuroglycopenic symptoms. Very important to understand that severity of hypoglycemia is often related to the neuroglycopenic symptoms, as the autonomic symptom may be vague and at times can confuse with other diagnoses. So neuroglycopenic symptoms are probably more characteristic of hypoglycemia and can be related to the degree of hypoglycemia, so that severe hypoglycemia can be associated with loss of consciousness, convulsion, and even coma. How to assess when you see a patients of documented hypoglycemia? Now you have to keep few points in mind. Number one, whether patient is in stable or in serious condition, very important. Second, whether it is occurring in your OPD or community setting or in hospital. Whether the presence of comorbidities, I will discuss about later on. And it is very, you have to be careful about the medications used. As we know, a lot of medication can cause hypoglycemia in a person who has got no history of diabetes. And I would like to add one point. Any otherwise healthy person who has a documented episode of hypoglycemia need proper clinical and biochemical evaluations. Very, very important. Now the clinical status I have already mentioned. If patient is healthy, no underlying medical conditions, no drug history, feel otherwise okay, you have to go for detailed clinical examinations and investigation, because most of the time these cases are due to endogenous hyperinsulinism or fictitious hypoglycemia. I will talk about later on. So healthy hypoglycemic patients documented need further evaluation. And whereas in patients who are ill, hospitalized, patient in acute hypoglycemic state, first thing, treat the patient. Don't go for investigation or do anything. First stabilize the patient, and if you have chance, go for investigation, that I will tell about. So if you have chance to talk to the patient who is having documented hypoglycemia, take clinical history, talk about drugs he or she is taking, and try to understand the underlying any medical condition. It is very important that hospitalized patient may have multiple comorbidities and complex causes of hypoglycemia, including iatrogenic. So be very careful about that. So if patient is seriously ill, treat hypoglycemia. If you have time, take history, clinical examination, and send whatever biological material you need to test to diagnose hypoglycemia. I'll talk about later on. So one very important thing, as I am an endocrinologist from my point and also for you, any patients of hypoglycemia otherwise healthy, be very careful of adrenal insufficiency. Even subclinical adrenal insufficiency can precipitate hypoglycemia in any condition of stress. So for example, any septic conditions, patient given any drug that can cause hypoglycemia, or acute renal or liver disease, or even acute sepsis can precipitate stress-induced adrenal insufficiency. And it is also very important, please take history whether patient is, particularly for us, we take history whether patient is having already diagnosed case of adrenal insufficiency. That can be primary or can be due to the pituitary and hypothalamic disease. And it is very important to understand that secondary adrenal insufficiency is very important, because there may be multiple hormonal deficiency like growth hormone and other hormones, and that can actually lead to even profound hypoglycemia, and we have to replace all these hormones. I am not going into detail. So you can have a look into the etiology of primary or secondary adrenal insufficiency. This is very important. And on clinical point, we have seen patients of known adrenal insufficiency, they may forgot or non-compliant in taking replacement dose of hydrocortisone. So those patients can have an episode of adrenal insufficiency and hypoglycemia. Regarding medications, you know there are medications. I'll show you a list of medications. And alcohol. It's very important that alcoholic patients, if they are elderly, particularly having liver disease or kidney disease, and in presence of some drug, can precipitate an acute episode of hypoglycemia. Take history, go through all the details of drug history from the patients, both in-house and at home. And not last but the least, there are multiple case reported have shown therapy, herbal therapy, and alternative therapy can lead to hypoglycemia. There are case reports like zinc in COVID-19 patients can cause hypoglycemia and hospital admissions. I have just noted there. Severe hypoglycemia over-the-counter supplement for increase in libido. This happened in Singapore because they contaminated the drug with glibenclamide. So there are other unusual outbreak of hypoglycemia due to contaminations, and there is herbal remedies of different kinds. There are case reports to show that they can cause hypoglycemia in an otherwise healthy non-diabetic patient. So we have to talk about this also, but take a long history if possible. This is a list of causes of hypoglycemia. I am not going into detail. I will talk about few parts of this chart. It is very important to understand that hypoglycemia in an otherwise healthy person, you need to have very close clinical history and lot of investigations. If you see the drugs causing hypoglycemia, apart from anti-diabetic agents, hypoglycemic agents and alcohol, there are very few evidence-based data, and I have taken this from Endocrine Society guidelines, and there are few drugs that have got moderate quality of evidence. Rest of drug have very poor quality of evidence. So we often call about beta blocker, AC inhibitors, ARB, fluoroquinolones, but except the gatifloxacin, there is few cases, maybe 25 or more, they have shown that can actually cause hypoglycemia in a non-diabetic patient. So regarding drug, there are few drugs which have got a high evidence of hypoglycemia, excluding the anti-diabetic agents and alcohol. There are other alternative causes which can cause hypoglycemia. I will talk about what are the alternatives, like insulin or insulin-like growth factor mediated hypoglycemia. Bariatric surgery, as you know, it can cause fictitious hypoglycemia. You have to be very careful about this drug taken by somebody by mistake, accidentally or intentionally. Take the history, and very rare cases of insulinoma, and one very rare case of malignancy that is called Warburg effect. Actually, large mesenchymal tumor with metastasis can cause hypoglycemia, or any malignancy with excess secretion of IGF-2 or antibody can cause hypoglycemia. These are rarely reported. Critically ill, we have known that falciparum malaria can cause hypoglycemia. Similarly, acute renal failure or liver failure also can cause hypoglycemia in different settings. When there is no underlying etiology from clinical examination and history, we have to go for other testing, including some supervised testing. I will talk about briefly on that. Let us talk about few even uncommon causes of hypoglycemia. One is an autoimmune syndrome. This is antibody mediated. There are mainly two types. One, insulin autoantibodies. They are antibody against the insulin, and they actually stimulate the insulin receptor, causing hypoglycemia. This is called IAS or insulin autoantibodies. These are quite uncommon outside Japan and almost not seen in Caucasians, and it is very rarely seen in India. Few case reports. These are antibody mediated, and most of the time they have a precipitating factor like drugs. In Japan, methimazole is one of the drugs. Similarly, viral infections, other drugs, medications can initiate the antibody production and hypoglycemia. Most of the patients recover spontaneously with initial supports, 80 to 90% recovery rate, and most of the time removing the offending agent, for example methimazole, can resolve the problem. and treatment is symptomatic. There are few case reports where we have to use the immunosuppressant like high dose cortisone or azathioprine or rituximab to reduce the antibody titer and hypoglycemic episodes. Type 2 diabetes, type B insulin resistance, even rare. This is the antibody against the insulin receptor. Here the peculiarity is that patients with features of insulin resistance, and the antibody against the insulin receptor is partial agonist. They can stimulate insulin receptor also, and the patients with features of insulin resistance, hyperglycemia, can an episode of severe hypoglycemia. They are very rare, mainly present in black women in middle-aged, and they present with all the features of insulin resistance. The prognosis is bad because most of the patients develop lot of complications due to insulin resistance and malignancy. So they die from mostly cardiovascular and malignancy related complications. Insulinoma, it is quite rare, 1 to 4 or 5 per million population per year. Again, it is a Western data, it is quite uncommon. They have mainly two peaks, one in childhood, mostly due to genetics. I am not going into details. And in adults, they are mainly sporadic and can be part of MEN1 syndrome, around 10 to 30%. Again, this is Western data. So they are mostly single, small, less than 1 centimeter diameter, and it can be present both in the head, body and tail of the pancreas, in evenly distributed. And diagnosis is mainly clinical and biochemical testing, and it is very difficult to diagnose at times because of its small size. But now we have endoscopic ultrasound, CT, MRI and PET scan that can pinpoint in 90 to 95% of cases. I am not going into detail, but again they are very rare, and it is mostly a diagnosis by exclusion. Treatment is surgical enucleation in most of the cases, and they are rarely malignant. So insulinoma is probably the diagnosis of exclusion in most of the hypoglycemic patients. But clinically it is very important. If you find a young patient with recurrent hypoglycemia, very likely it can be a part of MEN syndrome. Necidio-blastoma, even rare. This is a benign hypertrophy of beta cells that can also cause hyperinsulinemia and hypoglycemia, predominantly postprandial. Now the choice of test, I have already told you, if the patient is stable, if there is unprovoked hypoglycemia, you have to go through this glucose insulin draw a blood, they send it to the glucose insulin C-peptide, beta hydroxybutyrate, proinsulin concentration, and where you suspect that the patient might have taken oral hypoglycemic agent accidentally or deliberately, test for sulfonylurea and other drugs for toxicological testing. If patient is not at hypoglycemia but as an episode of hypoglycemia, we are unable to test that, you can provoke hypoglycemia by fasting, and mainly we follow two methods that I will just tell you. So one is a fasting and one is a mixed meal test. Now if we got the reports that I have just mentioned, the blood test, I have sent them to the lab. If we get the report, we can just exclude the different cause. I have just highlighted two important causes. That's one is the insulinoma. You can see the insulin level is quite high, C-peptide is high, proinsulin is high, and there is low beta hydroxybutyrate. It's a one diagnostic point. This is a clear picture of insulinoma. What about the antibody-mediated hypoglycemia, that is insulin autoantibodies? First thing you have to do, you have to test for insulin autoantibodies, and if you measure insulin, it will be very high, in thousands. The very high insulin indicates towards insulin autoantibodies. So a very high insulin, C-peptide and proinsulin is also indicative of insulin antibody related hypoglycemia. So when the antibody is positive, it is antibody related. If there is negative, if you have a high insulin C-peptide and of the insulin more than 25% is a proinsulin, it is very likely insulinoma with the background of recurrent severe hypoglycemia. So if someone is having an episode of hypoglycemia but resolved, we want to induce hypoglycemia to know what are the cause. Mainly for those with postprandial hypoglycemia, I have already mentioned, like post-gastrectomy or say insulinoma or necidoblastoma. A mixed meal test will can have a differentiating factor, because this necidoblastoma and this whatever we call post-gastrectomy hypoglycemia can be precipitated by this mixed meal test. Whereas if we go for fasting, 72-hour fasting in most of the cases can pick out the insulinoma. And if we need further upgradation of testing, we can do a test called glucagon testing to increase the insulin secretion to show the difference between normal versus insulinoma. If you give a glucagon injection in a otherwise hypoglycemic patient to identify the patient is having insulinoma or not, if you give injection, there is at least 25 milligram of increase of glucose within next 5 minutes time in case of insulinoma compared to the normal person. The reason behind is that in case of insulinoma, this glucagon will increase further secretion of insulin and increases blood glucose level due to neoglucogenesis. As far as management is concerned, it is absolutely symptomatic. I have already mentioned in acute stage, please treat the patient fast and then go for investigation and have provocative tests. For otherwise, patient is healthy, having an episode of hypoglycemia, they give oral glucose, he can eat. There are, the methods of doing these things. There's rule of 15, give 15 grams of glucose, wait for 15 minutes, check sugar. If it is again below 70, give 15 grams of glucose, wait for 15 minutes, recheck. If it is normal, ask the patient to have some meal with a good amount of simple carbohydrate, and you then go for whatever investigation and something for that. If the patient is very sick, give IV glucose, and if you have an access to glucagon, can give injection glucagon to raise the blood glucose. Regarding glucagon, it has got very short acting, so it can raise blood glucose level, but you have to back up with IV or oral glucose. So this is in short in the management. So the take home message, it is uncommon, but when common, you have to have apply your brain to identify the cause and manage, because they have got varied reasons. Most important thing is the clinical assessment. It may be insulin dependent, it may be insulin independent. Biochemical testing, mainly identify the cause. You go for mixed meal or whatever supervised test, fasting for 72 or something like that. Even you can go to glucagon injection, even you can go for calcium challenge to identify insulinoma. And for insulinoma, now we have PET scan to identify almost smallest size of insulinoma. Autoimmune disease like insulin autoantibodies and insulin receptor antibodies are quite rare causes of hypoglycemia, and again you have to identify the antibody in autoimmune hypoglycemia. But this type B insulin antibodies that I have shown you, it is very difficult to identify that, as the test is not available to detect antibody against the insulin receptor. It is quite, it's not available in our country in most of the centers, and they are quite rare. So I must stop here, and if you have any question, any comment, please do. Thank you.
It was a fantastic deliberation by Dr. Chatterjee. It was an elaborate one, covering all the nitty-gritties of the subject. So I would suggest that if the floor is open for questions.
I have a question.
Before
that,
sir, one moment. As a prerogative of the chair, I have two issues to bring to you. One is following bariatric surgery. I have seen number of patients who are non-diabetic going into hypoglycemia.
Yeah.
That is one part I think should be pointed out. Number two, your understanding of giving acarbose or for other reason, any other drugs which can prevent these kind of situations.
We have mainly used acarbose and also octreotide in some rare cases. So
Dioxide has been some reported usage. And
But
elementary hypoglycemia, I mean, maybe because of these bariatric surgery,
Sure.
right?
We the physician actually commonly face the hypoglycemia in our day-to-day practice when the patient's renal status going down. And number two, the sepsis. In fact, we have found several sepsis patients initially present with the hypoglycemia. So do you suggest what kind of treatment, is there any role of the steroid other than the glucagon and IV dextrose injections? What are the way we can tackle this situation? Because sometimes the hypoglycemia is so refractory, so frequent. Even after giving the glucose infusion, we are not able to maintain the blood sugar level of the patients. Other than the control of the parent disease, there is the infection.
If you allow me to answer, if I will divide into two. If you say that it's a refractory hypoglycemia, I will look for at least 2-3 causes apart from this acute setting. One adrenal insufficiency is one of the important cause of this refractory hypoglycemia. Apart from that, there may be background cause of insulinoma may be there, one of the cause of refractory hypoglycemia. Refractory hypoglycemia in acute setting is very difficult to pinpoint. We have to do two things. Number one, we have to first correct the underlying cause, sepsis, because there is a complex phenomenon. You have to have sepsis, renal failure, liver dysfunction. This can lead to hypoglycemia. We have to correct that and treat symptomatically. That is number one. We have to be very careful about drugs. Drugs are the major culprit in causing hypoglycemia in acute settings. So go through a history of all the drugs, and even at times there may be misadventure or accidental application of some drugs that can lead to hypoglycemia. So I will rather go through fast. I will try to correct the underlying cause, treat individual components of the problem. Vis-a-vis, I will treat the hypoglycemia, and if the patient is stable, I will go for further test to identify the underlying cause. It is a very complex situation because, again, I have shown you in a slide, in most of the acute setting cases of hypoglycemia, there is multiple etiologies. So it is very difficult to pinpoint. First to stabilize, second is to correct the underlying cause, then we look for any other cause of hypoglycemia.
You have rightly pointed out.
Huh?
One is insulinoma and another is adrenocortical failure.
Absolutely.
These two are most important.
You have to have Addison's disease in your mind.
Yes,
that is very important.
Dr. Ponsali, please.
Sometimes we find young healthy individual without any comorbidities or insulinoma with the hypoglycemia, and especially it occurs after high carbohydrate meal, and when we measure their insulin level and see peptide, that is higher, and they respond, as you have shown that in IES, they respond to low carbohydrate meal and sometimes acarbose. So is it reactive hypoglycemia in pre-diabetic patient when insulin secretion is high? Because over the years, these patients, few of these patients, they develop frank diabetes.
It is very difficult to explain, but probably it may be a part of type B insulin resistance. It is probably at the insulin receptor level, or there is three types of insulin resistance, A, B and C. B is what I have explained to you. They may present with severe hypoglycemia. There are cases where these patients with suggestive of insulin resistance rather, or high insulin, can have partial agonistic antibody that can cause hypoglycemia at times. So yes, it can happen. It's probably due to antibody mediated.
Thank you.
Thank you. Any other question?
Nanda, a very basic question. Your first slide was showing the cutoff for hypoglycemia as 55 milligram per deciliter. So what we should, your first slide?
50 per 10,000 population in hospitalized
No,
patient.
55 milligram per deciliter.
55.
So what should be our standpoint? What should be our cutoff for taking a diagnostic for non-diabetic hypoglycemia? It should be 55 or 70?
55.
55.
It is taken 55. You have asked me a very important question. I was expecting that. Why 55? It is arbitrary, but the logic behind that, around 65, below 65, up to 55, around 55 in non-diabetic patient, you have two physiological changes. One, your insulin secretion is cut off, normal physiological secretion, and your counter mechanism is at the peak. So this is where you have hypoglycemia going downhill. So this is taken as arbitrarily because of you have a least amount of insulin secretion at the blood glucose level of 55 in physiological condition.
Thank you. Thank you, Dr. Chatterjee, for your marvelous presentation.
Thank you.
Thank you, Speaker. Thank you, Chairperson.
Let's
On
close the
behalf
session.
of Howrah Diabetic Society, sir, please be there for the felicitation. I would like to request Dr. Shah to please felicitate our Speaker and Chairperson.